بسم الله الرحمن الرحيم. بشكر الأخ والزميل العزيز أستاذ دكتور سامح توفيق على دعوتي. الحقيقة سعيدة بوجودي مع حضراتكم، وبهني دكتور سامح على نجاح المؤتمر. بشكر دكتورة هدى على التقديم الجميل وكل الشير بيرسونز. هتكلم عن الجراي زونز in growth disorders. الحقيقه انا اخترت الموضوع ده لان في حاجات كتيره، مش بس طبعا في الجروث بتبقى debatable، واحيانا it's not a clear yes or a clear no, and there are a lot of areas of overlap, and this is what I'll try to cover in growth. We all know that growth starts from prenatal life to adolescence. We have intrauterine period, insulin, growth factors, maternal health, nutrition. In infancy, again, we need proper nutrition. In childhood, growth hormone takes the upper hand, T4. And finally, in puberty, we need synergistic effect of sex steroids working hand in hand with growth hormone to achieve growth. And this is the simplified classification of short stature that we all know, but in fact, short stature is not that simple. It's really a complicated thing that needs to go more and more in depth to reach the final diagnosis and treatment. And this is simply how we think when we see a short child. If the child is dysmorphic, we go for syndromic short stature. Is it disproportionate short stature with its causes, or is it proportionate in a non-dysmorphic child? And here we have to exclude first normal variants, undernutrition, chronic illness, SGA, endocrine, and finally, when we cannot reach a cause, it's idiopathic short stature, although right now, it's not idiopathic anymore with the advance in genetics and discovery of a lot of genetic mutations that we used to say that it used to be idiopathic. So we are starting from baseline investigations up to genetic testing. We start by the baseline investigations, celiac screening, karyotype for short girls. And when we exclude these, we go for endocrine assessment, thyroid function, growth hormone stimulation, IGF-1, IGF-BP3, and we put these together in addition to MRI sella turcica, of course, the bone age, and the final step which captures the diagnosis is genetic testing. And this is to show you a taste of our golden tools. And what we do is that we put these together and think, what is the cause of short stature? What's the diagnosis? Here you can see our golden tools added to MRI sella turcica, genetic testing, putting these together in order to fit the pieces of the puzzle and reach the diagnosis of short stature upon which the treatment lies. And therefore, it's very important to watch your step when dealing with short stature to avoid the pitfalls. It's very important to avoid the pitfall in diagnosing and managing short stature, which really affects the outcome. And this is a very basic slide, but it's an important one. It's not a debatable child. Here, avoid basal growth hormone measurement. Of course, 2 growth hormone stimulation tests are needed to diagnose growth hormone deficiency, with very few exceptions that I'm going to tell you. Thyroid function should be done prior to growth hormone stimulation test. Karyotype should be done to short girls. Bone age does not indicate a definite diagnosis, but it's delayed in endocrine disease. MRI sella turcica could be the clue to the diagnosis. And finally, don't forget to exclude normal variants, nutritional, chronic illness before jumping to endocrinal causes. So this is a very classical slide, which is a very basic introduction to what's going to be debatable. And here you can see a list of FDA-approved indications for growth hormone therapy. And let me add that Noonan syndrome is recently approved in Europe as well as an indication for growth hormone therapy. And now let me take you through a zoom into some debatable aspects in growth disorders. Okay. Sorry, it's moving. Okay. This is a 10-year-old girl who came with proportionate short stature. She was born with normal weight and length, but she came very short. Growth velocity is very poor. The typical doll-like face, abdominal fat, excess abdominal fat, and a normal IQ. And here you can see the growth chart. The girl started to decelerate at the age of 2 to 3 years. Celiac screening, thyroid, adrenal functions were normal. And the growth hormone provocation by 2 tests came very low. IGF-1 is very low. Bone age is delayed. And this is a very easy diagnosis. This is isolated growth hormone deficiency. And MRI Celatosica revealed anterior pituitary hypoplasia. And please remember this diagnosis because we're going to use it later in a quiz. Now, looking at molecular mechanism of action of growth hormone, imagine that this is the wall of the liver cell. This is the liver cell membrane. This is the growth hormone receptor formed of 2 parts. Each part has got an extracellular, transmembrane, and intracellular part. What happens is growth hormone molecule binds to the receptor, causing dimerization. The 2 parts come together and it binds to JAK2 with addition of phosphate group, causing phosphorylation of receptor complex with binding to STAT protein. Again, phosphate is added to STAT, causing its phosphorylation, and then it enters the nucleus, causing transcription of target proteins, stimulating MAP kinases, releasing IGF-1, which passes to the circulation, promoting the growth effect. So at any step, any genetic mutation could lead to growth failure. And here you can see the diagnostic criteria proposed by Growth Hormone Research Society. Once hypothyroidism has been excluded, proceed with growth hormone stimulation. MRI pituitary is very important in cases of growth hormone deficiency, and especially if there is more than 1 pituitary hormone defect. Also, 2 growth hormone stimulation tests are needed with very few exceptions. Another important point is that the cutoff limits for defining growth hormone deficiency varies according to different assays. And in the table at the right side, you can see the cutoff limit using variable assays. But in most of the assays, it's less than 7 nanogram per ml to diagnose growth hormone. Also, 1 growth hormone stimulation test is enough if you have a definite CNS pathology like craniopharyngioma, cranial irradiation, multiple pituitary hormone deficiency, proven genetic defects in the axis, or congenital malformations. Also, growth hormone stimulation test is not needed at all in cases of Turner syndrome, Noonan syndrome, Prader-Willi, SGA, and chronic renal insufficiency. So these are exceptions here. Now let's get back and start the first debatable point. The girl is 10 years old. Would you like to do priming or not before growth hormone provocation? To prime or not to prime? Some references suggest priming because it reduces the false positive rate of growth hormone stimulation test. Other references suggest not priming because priming briefly augments the growth hormone response, which then returns to suboptimal concentration, and it may result in failure to treat children with transient peripubertal growth hormone deficiency. And some references lie in between. They suggest priming children only with delayed puberty. And I follow this theory, priming those with delayed puberty. And this is the protocol of priming. You can see here the doses that we give in boys and in girls for priming before growth hormone stimulation test. About 1/3 to half of pediatric endocrinologists prime before growth hormone stimulation if the girl is above the age of 8 and the boy is above the age of 9. So this is the first debatable point. Another thing is obesity. Obesity reduces growth hormone secretion by itself. It increases somatostatin tone, and reduced growth hormone by itself increases the visceral obesity, and the vicious circle goes on. And based on that, there's a blunted response to growth hormone, giving a false positive growth hormone deficiency in obese children. And that's why there's an urgent need for BMI-specific cutoff levels for peak growth hormone during provocation in childhood and puberty. It's very important to correlate the growth hormone level with the BMI. In obese child with poor growth, it's very important to exclude endocrine disease before doing growth hormone stimulation, meaning thyroid and Cushing. What about measuring IGF-1? Please remember that IGF-1 varies with age, and it could be reduced by itself in those with poor nutrition, hypothyroidism, chronic disease, renal failure, and diabetes. So this is very important to put in mind. Also, IGF-1 rises during puberty, and therefore it's very important to calculate IGF-1 standard deviation score. Don't take just the number according to the age. It's correlated to age, puberty, nutritional status, and a lot of other factors to avoid bias. And this is a very nice article setting standard deviation, the mean and standard deviation values for boys and girls from 6 to 18 years, as you see, setting the IGF-1 according to standard deviation and not by numbers. In infants, the situation is even more critical. This is a 20-day-old newborn presenting with neonatal jaundice, generalized tonic-clonic convulsions, micropenis, depressed nasal bridge. The baby had indirect hyperbilirubinemia, and the random blood sugar was found to be very low. And the blood sugar was not responding to usual lines of treatment. So the next step is withdrawing a critical sample. And the hypoglycemia was found to be ketotic. All the labs were normal apart from a very low growth hormone. So the diagnosis here is congenital growth hormone deficiency. And the clue here is hypoglycemia and micropenis. The MRI cellulosica revealed ectopic posterior pituitary with agenesis of the infundibular stalk. Indeed, MRI is a very useful tool for diagnosing the cause of growth hormone. As you see, there's a very wide spectrum of anomalies associating pituitary, starting by hypoplasia, aplasia, ectopia, and the presence of an abnormality within the hypothalamo-pituitary axis by MRI provides a very powerful supporting evidence for diagnosing growth hormone deficiency. So MRI pituitary is a very useful tool indeed. Genetic short stature is a very complex process, and it's highly heterogeneous. It could be prenatal, mild or severe, due to genetic mutation in the hypothalamo-pituitary growth axis, part of endocrinopathies, skeletal dysplasias, syndromes. And this is how there is coming new generation sequencing technique to discover more genes implicated in the regulation of growth novel therapies. And here you can see in a very simple slide the technical approach, starting from CGH array, ending by whole exome sequencing. So indeed, genetic testing confirms the clinical diagnosis of short stature. And finally, there is the whole genome sequencing, which is novel genes disease. It could discover even novel genes. So as you've seen, short stature is a multifaceted diagnosis. It's not as simple as it might appear. Now, moving to another debatable point, growth hormone is needed throughout life. And growth hormone deficiency in transition phase is very important to bridge the gap. And this is another very important gray zone in growth. Transition phase is the phase between late puberty and the near final height. And it's very important to cross this bridge safely from late puberty to adulthood. We all know that the effects of growth hormone deficiency vary. In childhood and puberty, it's needed for growth, linear growth, and higher doses are needed. In adulthood, it's needed for metabolic purpose, and here lower growth hormone doses are needed. And even more critical is transition period. And the plan for managing growth hormone deficiency in transition period, first of all, do we need to retest growth hormone or not? What is the approach if growth hormone retesting is needed? And shall we continue growth hormone for life or stop growth hormone? Now let's take this very simple quiz. This is a 15-year-old girl with Turner syndrome who started growth hormone at the age of 7. She's now on cyclic therapy. She's not gaining good height. Her bone age is 14.6. Would you like to retest growth hormone IGF axis in a girl with Turner? Yes or no? Thank you very much. Of course not. At the beginning, we do not even need to do a growth hormone stimulation test. This is a case of Turner. And once she achieves the final height, you do not. The second question, would you like to continue growth hormone for life in a girl with Turner? No. Thank you very much. So the story ends when the bones are closed. So in the following disorders, SGA, chronic renal disease, Turner syndrome, ISS, Prader-Willi, growth hormone is stopped when linear growth is completed. So as you've seen, retesting growth hormone secretion is like lights and shadows. It's really difficult. And this is a very nice article published in Hormone Research in Pediatrics on the guidelines for growth hormone therapy and diagnosis during transitional phase. You can see that the authors classified 2 groups: low likelihood of permanent growth hormone deficiency and high likelihood of permanent growth hormone deficiency. The low likelihood is the patients previously diagnosed with idiopathic isolated growth hormone deficiency or idiopathic isolated growth hormone deficiency with only 1 additional growth hormone deficiency plus normal MRI pituitary. The group with high likelihood of permanent growth hormone deficiency includes those with genetic or molecular defect, structural abnormalities, multiple pituitary hormone deficiency, or organic disease. So simply, if the child falls under the category of low likelihood of permanent disease, retesting is needed because we need to decide whether to continue or not. But if the child lies in the category of high likelihood of permanent growth hormone deficiency, retesting is not needed. You just continue growth hormone for life. So this is the summary of this nice article. If you have high likelihood of permanent growth hormone deficiency, retesting is not needed. Growth hormone deficiency is confirmed. Low likelihood of permanent growth hormone deficiency, stop the growth hormone for 1 month washout period, do baseline IGF-1. If normal, growth hormone deficiency is excluded. If low, do a growth hormone stimulation test. If low, growth hormone deficiency is confirmed. But there are some exceptions for such cases, and these are the only exceptions. Cranial irradiation may become growth hormone deficient with time. Anterior pituitary hypoplasia and ectopic pituitary with a normal pituitary stalk have a high possibility of recovering normal growth hormone on retesting. Ectopic pituitary with agenesis of pituitary stalk will have permanent growth hormone deficiency, so you will have to continue. So retesting will be done only in the first 3 categories in order to decide whether to continue growth hormone or to stop. Now, let's get back to our cases, and please help me in this. In this case, this is anterior pituitary hypoplasia. Would you like to retest or continue? Retest, because there is a possibility to recover. In this case, this is ectopic pituitary with complete agenesis of infundibular stalk. Would you like to retest or just continue? Thank you very much. Yes, continue. There's total agenesis. It will continue for life. And ITT is the gold standard test for diagnosing growth hormone deficiency. And the cutoff proposed by SP is 5 nanograms per ml. By the Growth Hormone Research Society is 6 nanogram per ml. It's not like in children. And here you can see that the growth hormone doses goes down with different periods of life. And when to retest is based when the growth velocity is less than 2 to 2.5 centimeters per year. Now, the last debatable part is puberty. Growth and puberty, indeed, they are interrelated. We all know the definition of precocious and delayed puberty and the normal pubertal range lying in between. But even what's more difficult is the early but not precocious and the late but not delayed puberty. And a lot of children, especially in Arab countries, lie in this zone. So indeed, there are population differences, and the definitions of delayed and precocious puberty need to be revised between Europe and Arab countries. And therefore, there are emerging differences in the definitions of delayed and precocious puberty. This is a 9-year-old girl who came with short stature and early puberty. I'm saying early, not precocious, because she's 9 years. Her height is very low, -2.8, breast stage 3. Her growth hormone stimulation is normal, and the bone age is advanced, 11.5, and the girl is 9 years. Other than that, everything is normal. Would you like to wait, or would you like to give growth hormone only, or would you like to combine growth hormone and GnRH analog? A very difficult question. We face this a lot, especially here in Egypt. We see this a lot. What would you like to do? Who would give growth hormone only? No one. Who would give growth hormone and GnRH analog? Yes, I would do the same. Thank you very much. Although we all agreed on this, this is still not FDA approved, but I think this is the right decision. The girl does not have a good chance for height. Because as you've seen, sometimes the decision is not that simple. Not all cases are straightforward. This is a very recent article published in 2020 highlighting combined therapy with GnRH analog and growth hormone, increasing the final adult height in those with short stature and normal pubertal onset. And take care, in this paper, they included the normal pubertal onset and short stature. So it's even worse if there is early pubertal onset with short stature. And what they found is that combining growth hormone with GnRH analog improved the final height in those with idiopathic short stature and non-idiopathic short stature, but the outcome was much better in non-idiopathic short stature. And here you can see the results of the table. Significant difference in the final adult height standard deviation score when giving growth hormone and GnRH analog together. Now, let me show you the other side of the story. Some papers see that this is too expensive to do for a child. Expensive therapies in children, benefit versus the cost of combining growth hormone and GnRH analog. And in this paper, they found that doing this adds only 5 centimeters to the final height. And it should be considered on individual basis because it's a very expensive therapy. Each child will cost about €2,700, which is very expensive for 5 centimeters. So this is the other side of the story. So sometimes when we ask ourselves, which way shall we go? This is the gray zone. And what if both ways could be right? Sometimes doing this or that should be correct. So it's not always black and white, as I showed you. And I focused on the growth, but I think in all medicine, there's always a very big gray zone that we move on. So we need to treat on individual base because every child has got his or her own story. We need to calculate the cost-benefit ratio and to avoid unnecessary use of therapies. Use it properly at the proper time, at the proper dose. And growth hormone and even other endocrine therapies are very expensive. We need to increase the benefit in relation to the cost and to minimize the side effects as well. So my final conclusions are diagnosis of short stature is a multifaceted condition. It's not simple. Be aware of inter-assay variability when diagnosing growth hormone deficiency. Most authors recommend priming prior to growth hormone provocation test. girls above the age of 8 and boys above the age of 9. Personally, I do priming if there is delayed puberty. Obesity results in blunting growth hormone stimulation test. Be aware of this. It's not as bad as it might appear. The proper decision whether to retest or not is very important in transition phase in order to decide whether you will continue growth hormone therapy for life or not. Remember that growth hormone dosing differs in different periods of life. Pediatric is different from transition phase, different from adult. Both delayed and precocious puberty could affect the final height, and it's very important to put the growth and puberty hand in hand when managing any child. And of course, calculating the cost-benefit ratio is really important, especially that all our therapies in endocrinology are really expensive. And I believe there is still a lot of gray zones, not only in growth, in a lot of things. So this is how I feel when dealing with any child with growth problem or even an endocrinopathy. We need to be careful in the diagnosis, in the pitfalls, in the treatment, and in calculating the cost-benefit ratio to offer the best for the patient. But I think there is more to come with advance of genetic testing. I think that the gray zones are going to be less and less, hopefully so. Thank you very much.